on this episode of A Tale of Two Hygienists.
When I joke when I'm lecturing, I'm like, in school, I think the only thing I remember is like Streptococcus mutans. Like that's pretty much what causes caries, but it's so multifactorial. It's really so much more than that. You know, it's like, why do you see some kids come in and they have like all this gunk on their teeth and they don't have one cavity? And then you see one with perfect oral hygiene that's just bombed out everywhere. You know, there's so much more to it, you know, nutrition, pH, saliva, socio-determinants of health, all of those things, you know, play into cavities. A lot of dentists, if they're not properly assessing the lesion, they're drilling into a lesion that's inactive that maybe would just stay that way forever, you know, or you can continue to treat with, you know, high fluoride toothpaste or varnish, or, you know, you don't really need to. And now we're setting that patient into the restorative cycle unnecessarily because it's not an active lesion.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 431. I'm your host, Andrew Johnston, and thank you so much for joining us today. We have a great episode with you. We're joined today by Jessica Woods. We talk about assessment and caries diagnostics. It's a really great episode. As I mentioned in the last several episodes, I'm traveling this week and next week, so this is all for our intro. Hooray! And now, enjoy the episode with Jessica Woods.
A tale of two hygienists.
Welcome, everyone, into the interview portion of the podcast. Very excited to be joined today by Jessica Woods. Jessica and I just recently connected over LinkedIn. I think as we kind of get into this cariology series that I have envisioned, you know, what had happened, I think we had posted something and you commented about it, and I'm like, holy crap, that's a really brilliant response. And then I started like, sorry to be kind of creepy, but like started looking at some of your LinkedIn stuff. I'm like, oh, okay, she speaks on cariology. How is this like kismet? Like, this is perfect. Thank you very much for being on. This is awesome.
Thank you so much for having me.
I always like to start our conversations with getting to know you, like who are you and why is maybe either cariology or caries detection or whatever your specialty is, like why is that something that like you're drawn to? But even before that, like what got you into dentistry?
So I come from a family of dentists, like dentistry. My grandpa is a dentist. He's been one of my biggest mentors. And he owned a couple of dental practices. You know, my mom worked there, my uncle worked there. It was just kind of a family affair. And so I started, I'll probably age myself, but I started just like punching x-rays out of mounts and, you know, paper charts, like mounting the papers and like looking the little tabs and things. So I'm pretty old school. And I just, you know, grew up around his dental office, and then they started letting me suction. And then my mom like basically bribed me to go to dental assisting school when I was in high school. And I was like, oh, I get to leave at lunch? Cool. Yeah. Okay, let's do it. And then, you know, I'm kind of the black sheep. So I was like, no, I'm not going to go into dentistry. And here we are 20 years later.
And loving it and thriving.
Yeah.
So, okay, one of the things before we get into talking about kind of what we have prepared for this one is I do want to go into just a little bit about your history, because you've worked in California for a long time and now you work in Nevada. Is that correct?
That's correct.
So tell me a little bit more about like your history, your pathway kind of from, you know, between the different states.
So when I was in California, you know, I started probably similar to how many people do, you know, getting out of school. I worked at a DSO for some time, which, you know, was much different than when you're in school. You know, has, you know, good things about it and not so good things about it. After about 5 years of clinical practice, you know, kind of just bouncing around, honing my skills and all of that, I just was like, I don't know, I'm kind of getting burnt out already, which I think I think that
sounds
like,
about right.
Yeah,
3 to 5 years, you start feeling it.
Yeah. And so I learned about the RDHAP license in California and decided to pursue it. I met the qualifications and I did it. And for those that don't know what RDHAP, it's a registered dental hygienist and alternative practice. So essentially it's like a direct access dental hygienist. You attend a program and then you take an additional license, and then you can basically practice without direct supervision. If you're in a health professional shortage area, you can actually have a brick and mortar or more of a community-based program. So kind of, different models, different RDHAPs are doing different things. And I did it and I loved it. I mean, really, I felt like I had been told thank you more times in like one day than I had in a year, working in private practice.
Yeah.
I mean, we need our private practice hygienists for sure, but like it was just so like rewarding, and I just knew that was like my space.
Yeah.
I've also always had a strong interest in business, and so it allowed me to kind of mash the two things that I like, to clinical
You
and
lost
business.
all of our hygienists. All right,
Yeah.
like business. Get this girl at the podcast. This
Yeah.
is terrible.
Yeah. Maybe there's one or two out there that'll be like, yeah.
Yeah. Oh, they've heard it from me for years. So I apologize, listeners. It's turning into a business podcast. So you say that was interesting to you. Now, with that, the alternative practice doesn't give you restorative license, or does it?
So you can get an additional certification to do intermediate therapeutic restorations. It's kind of like a virtual dental home model where you would be capturing, x-rays and patient records, and a dentist off-site may review them and, give the authorization for you to do some of these temporary restorations, especially when you're working out in, rural areas or community-based areas. And so I did have that certification kind of when it first started. And to me, that was really exciting and probably sparked my interest in cariology. I think, as a hygienist, we just have perio. And to me, it can get daunting. I know a lot of people are like real perio nerds.
Bless them. We need them. Yes.
Yeah. But I was like, oh, this is cool. It's like something I didn't really learn in school. And, you get to, just practice more at the top of your skill set. It's certainly something that hygienists are capable of understanding and doing. And
so let me ask you, I want to go through that workflow just a little bit, because I have a feeling it's different than what I did and what a lot of like quote unquote restorative hygienists do. So you take the assessments, the pictures, the x-rays, whatever, they send it off site, the doctor reviews it, the doctor says, yes, go ahead and place this, intermediate therapy. What type of materials are you using for this? And you're not prepping it all though, right?
No. So when I first was trained to do it, you would actually hand excavate some of the decay that was there, and then you would use a glass ionomer material over. Whether it was, the materials can vary, whether you're working on pediatric teeth or how many surfaces and what have you. Now, with the recent updates from the ADA restorative guidelines, they're recommending really you want to preserve as much tooth structure as possible. And I think with SDF coming on the market, you just place some SDF in there and it's going to arrest that lesion. And then you can place the glass ionomer over that. So you don't even really need to hand excavate. Sometimes I do, if there's, sesame seeds and gunk in there, that's going to like impact the bond of the...
Well, that's probably be a hygienist going and cleaning the teeth at that point, right?
Yeah.
Like,
did you have a Big Mac earlier? Because I see all these sesame seeds in there.
Oh my gosh. Oh man. All right. So you did that for a bit. You enjoyed it. You loved it. And then life took you to Nevada.
Yes.
And things are drastically different or a little bit different?
Just, I'd say a little bit different. I just was like, I knew I didn't want to go back to like private practice. I was like, public health is where I want to be. And so based on the experience I had in California, I was able to kind of locate, how things worked a little bit easier just based on that experience. And so I started working with a school sealant program there. The model in Nevada, it's called a public health endorsed hygienist. So it's a bit different. The pathway is basically what you have to do is you have to develop a program. So you come up with like a protocol of like what your program is going to be and like the procedures you're going to offer and where you're going to work. There are some like regulatory things parameters you have to stay
Sure.
within, but you submit it to the dental board, and then once they approve it, you basically can go out and work on your own. The other option to become a public health endorsed hygienist, if you don't want to, take on the business side of things and start your own program, is you can work under someone else's program. So you have to first get the program approved by the board, and then each hygienist has to get approved. So in California, it's a very clear-cut pathway. Take the course, take the test, get the license. In Nevada, it's, some might think it's easier, but I think that it can be more objective. You're kind of more at the mercy of who's on the board and how supportive they are of hygienists, going out and doing this. So I think different programs have had an easier or harder time getting their programs through based on the composition of the board, which to me, I don't prefer that way. I like it, kind of cut and dry, because I know if I'm going to set out to do this, as long as I check all the boxes, I'm going to end up with the license at the end.
Right.
Well, from my experience, and I've mentored a lot of people that submit their programs to the board, there's a lot of subjectivity to it.
Honestly, that drives me just bonkers. And look, dental boards out there, I know you don't listen to this show, but if you are, we love you. We really do. You're out there to protect the public. We get it. But man, change at the times just a skosh.
Yeah.
Just a skosh. Let's be objective. All right. So one of the things that you do is, I could do so many things. One of the things you do is you do lectures on caries, cariology, and things like that. And I want to take probably the next, 10 to 15 minutes and talk a little bit about, in your programs, kind of where do you start the conversation about caries?
So, just very basic, the etiology of it. How does it start? How do we classify them? I don't know. Maybe I was slacking off in school. I'm sure I learned a little bit more than I remembered. But, I could tell you all the things about the periodontium. But when it comes to, caries, I'm like, did I learn that much? So I just take it way back and keep it real simple. And, just how do we get caries? What, plays a role in caries? But when I joke when I'm lecturing, I'm like, in school, I think the only thing I remember is Streptococcus mutans. That's pretty much what causes caries, but it's so multifactorial. It's really so much more than that. It's why do, you see some kids come in and they have all this gunk on their teeth and they don't have one cavity. And then you see one with perfect oral hygiene that's just bombed out everywhere. There's so much more to it, nutrition, pH, saliva, even socio-determinants of health, all of those things, play into cavities. So start by, just talking there, making sure we really understand, and then about the lesions, the classification systems, and then how do we detect? I work with a lot of hygienists, so we can't, quote, air quotes, diagnose because we're not capable of seeing a big hole in the tooth.
Because we're so dumb. We are the dumbest.
Yeah. So, how are we classifying caries? And, there's, a lot of aids and technologies and innovations coming to the market that, can enable, hygienists to, I think, objectively determine whether there's lesions there.
I think this would be a good place to kind of dive a little bit deeper into because, coming out of school, I'm trying to think if we had it in clinic or not. We definitely had it in our first place. I want to say in clinic, we even had the Diagnosing, right? That was the revolutionary technology of that day.
Yeah.
And we had to have our number written into the chart and all these different things. But we've come a long way since I was in school. So I think for the people that have been practicing at least as long as I have or longer, do you mind just kind of giving us a refresher of what are the kind of the newer tools out there? How do you use them? What are they detecting? Kind of how they work and stuff like that?
Yeah. So things like Diagnosing, they're using lights or lasers. We have really, I think, exciting technologies that are recently getting FDA clearance and coming to the market that are more optical agents where they're not using light or lasers. They're using basically a dye. That one in particular, am I allowed to say brands on here?
I would appreciate if you say brands,
okay.
Please. Yes.
One in particular is a technology called Blue Check, which is a paint-on caries detection. Kind of falls in this broader group of optical agents. There's also a brand called LumiCare where it's more of a rinse, and you rinse with it. You use a light to detect the caries, and then calcivis, they have kind of a wand that looks similar to like an intraoral camera that you press the button and it like dispenses the agent onto the tooth. All their technologies are a little bit different, but serve the same purpose. What's really exciting about them is that they can detect lesion activity. So that's why I get all like geeky over it.
Like where it's at, like active or
Whether
inactive.
it's
and
active or arrested. Because a lot of times, with white spot lesions, we just assume that it's an active lesion, but it could stay that way for a very long time. So these technologies can actually objectively help decipher that. Dentists, they're trained, there's characteristics, whether it looks like chalky or is it glossy, we can visually, but these technologies are actually objective. You apply them on there and it tells you, is it active or not? And a lot of, dentists, if they're not properly assessing the lesion, they're drilling into a lesion that's inactive that maybe would just stay that way forever, or you can continue to treat with, high fluoride toothpaste or varnish or, you don't really need to. And now we're setting that patient into the restorative cycle unnecessarily because it's not an active lesion.
Is there any prep work that needs to happen for these? Like, do they have to, prepare the surface in any sort of way so that the dye penetrates better or anything like that?
So you want the teeth free of biofilm. So ideally, after you're doing your hygiene visit, your prophy, or, a good brushing.
Pre-varnish though.
Yes. Yeah. And so then you can apply it on. It sits on the teeth for 60 seconds. You rinse it off, and then you basically see like blue spots on the teeth. The other really great thing about it is it can pick up pre-visible lesions. So lesions even before the white spot. So we're able to treat them with, non-invasively and, do targeted treatments there on those lesions.
Is this in conjunction with like your tactile? I mean, I don't want to say like, I don't want to say that we're always looking for like the easy way out, but I kind of feel like we're trying to always find like, you do this one thing and it's like 100% works every time. Like, do we need to do this in conjunction with like feeling and looking and
so those that are proponents of minimally invasive dentistry have actually really gone away from the tactile exam because that sharp explorer can actually do damage to the lesion. So if you do have demineralization happening and now you go poke around with a sharp instrument, we know that throughout the day, we're constantly in a state of remin-demin. Like you're depending on like when you're eating, things are remineralizing because of your saliva or demineralizing because you're eating something acidic. And so if there's already some level of demineralization happening and you take a sharp probe and you stick it right on there, you can actually like break through that demineralized area and actually cause more harm. Not only that is, this is a bacteria-driven disease. Now you take that probe has bacteria on it and you go around the rest of the mouth and you're just spreading that bacteria. This is always a pretty polarizing topic when it comes up in the course, especially when I have dentists there.
I bet.
They're like, what? Take this explorer from my dead lifeless hands, but really you have to get a good visual, dry the tooth visual, but it takes more time to do this. Yeah. And, we all know that time is so precious during our appointments.
When I was doing a lot of like caries risk assessments, and then the doctors called them out to me, right? So we can't diagnose, whatever. You can hear how bitter I am about that whole thing. Can't diagnose. We had a certain classification scale that we used. I think it was kind of adapted to what our office needed. Is there a particular caries classification system that you prefer that would include these free, or what did you call them? The lesions?
The pre-visible lesions.
Pre-visible lesions.
So, I think it's still yet to be determined because, these technologies are very, very new. Like most of them have just gotten their FDA clearance less than a year. And so still, preparing for launch. And so I think once you get things into clinicians' hands, for me, it's exciting because a lot of times things happen that you never would have imagined because we're all different. We all see things differently. But, from a caries risk, there's Canberra, ADHA, ADA has their own version of it. So there's different tools, but I think those are constantly evolving too. Because I even remember when, I learned Canberra in school, that was, I think, 15 years ago. I mean, we've learned more about caries and managing it and risk factors and things like that. So it's hard to say,
Well, and then, but I think when you think about Cambria, even back in the day, they had all this information. It just wasn't formalized, right? And then all of a sudden, several people kind of got together and they said, okay, we're going to have a summit, we're going to have a council, and we're going to have like what Cambria really means. We're going to identify these things. We're going to have a formal version of it, et cetera, et cetera. So you're right. I think that we are probably a little bit ahead of it, where if we all just start doing it, then there's someone's going to put it all together eventually. I want to talk a little bit more about interventions. It's a spectrum of interventions, and I think it kind of depends on kind of where their caries risk comes in, but also maybe other things that I'm not thinking about. Do you mind just kind of, what are you recommending, or what are you talking about as far as interventions go?
So yeah, on that spectrum, we really have kind of the patient level interventions and then moving into like lesion level interventions. I always, want to stay on the side where the patient stays out of that restorative cycle, because once they enter it, they don't leave it. You start with a one surface filling, when you're in your early teens, 20s. Well, 10, 15 years later, now it turns into a 3 surface and turns into a root canal and crown. And so that's, that's kind of where my focus is like doing what I can to prevent, working, especially with kids, preventing them from getting into that restorative cycle, because then it's just going to keep going throughout the lifespan. So for, from a patient level perspective, behavior, nutrition, using, certain products, understanding saliva. I mean, we could probably have a whole podcast on that, and I'm by no means the expert on that. But I think from my experience with working a lot with kids and at that age, and having a 3.5-year-old myself, nutrition just plays a huge role. The constant snacking, the acid exposure, and now that
and it's acid both ways though, right? Like, because anymore we see so much reflux in these little kids.
Yeah,
it's ridiculous what we see. So it's going down and also
totally. And I being a hygienist, I'm like, oh, my kid's not gonna just guzzle apple juice. And it's like, okay, well, if you're like, okay, shut the heck up, kid, and like drink the apple juice.
It's like we need to go. We're gonna give you apple juice in the car. Let's get going. Yeah.
You start to realize like it's hard for these parents. You're exhausted. So. I mean, it really has to start at a young age. I just took my daughter in, and she has like a small incipient lesion starting between E and F, and I'm like horrified. I feel like I've like failed as a mother, but it happens.
But the thing I like about that is like you also know there's so many factors. You're like, I can imagine your differential diagnosis going on in your head. Okay, it's like we didn't do this, but we did this. We did this. We did this. You should have offset this.
I should have done the turkey
conundrum.
when she was eating the pretzels that one day.
Exactly. Do you feel like we talked a little bit beforehand about like probiotics and that part of like what that could play in like our nutritional outlook on life? Is that something that you're a proponent of?
Yeah, to be honest, I'm still doing a lot of learning around that myself. I think there's a lot more products coming out. I mean, I know it's always kind of been there, but I think they're getting fancier with the strains and really understanding how they play in with the strains of bacteria in our mouth. One thing is like that you bring up with probiotics. I think the most important thing is we're always so concerned with, strep mutans and these, but the bad bacteria, but the good bacteria is so important too.
Absolutely.
So I do think that probiotics, in theory, play a huge role, because we don't want to, some of these harsh rinses and things can wipe out that good bacteria where we think like, I think patients think like, oh, I'll get it all out of there. But really, you could be doing more harm because you had a great balance in your mouth, and now you're disrupting that because of, too much alcohol and rinses or what have you.
Yeah. Let's get to lesion level interventions. This is, I'll be honest, the lesion level interventions is probably the most sought after information, I think, from the like, okay, let's just get at it. How are we going to attack these different, like on the scale of lesion size? What are we going to do for them?
Yeah. So for white spot, I think now with like technologies like Blue Check, we can see pre-visible lesions. You can target. I mean, I think as hygienists, we we're going to be her opponents for fluoride varnish, but how do we know that we're going to use, if it's appropriate to use a high fluoride toothpaste? Well, I would say if you start to see those pre-visible lesions, like let's prevent those from even turning into white spots.
Sure.
So we can use products like Curidont. That's a newer product that I think is, getting a lot of buzz lately. Resin infiltration. I think it's kind of a gray area for hygienists to be able to use.
Like depending on your state, if you're allowed to do it or not.
Because the last step is you do a polishing step with like a high speed. So I've talked with the company and I'm like, hey, we need to do some research about, can we accomplish the same thing by using the paste with like a slow speed or things, because I think that's where the gray area comes in for hygienists. But Curidont is definitely something. So for those that don't know what Curidont is, it's a P411, I think. Hopefully I didn't butcher that. But it's a self-assembling peptide. And so it helps to kind of build back the matrix of the tooth. And it's a pretty easy step. You basically etch because you just want to remove like the pellicle on the
that's
tooth.
Gordon Christensen.
I know. I was going to say that earlier.
Gordon Christensen just walked by.
I know. I was like, oh my gosh, Gordon Christensen's walking right by me.
Hi, Gordy.
Yeah.
He'll hate that. He's a big listener of the show. I don't know if you know that.
Yeah.
He's like, he hangs on every word we talk about.
Yeah, totally.
All right, sorry, continue on.
It's okay. And yeah, so, I think Curidont's going to be a great thing for our toolbox to have. We also have things like silver diamine fluoride, SDF. It can be used in primary prevention, so if you don't see anything there, you can use it. I've heard a lot of people, they'll place it before they do sealants just to make sure if there's, it's basically a medication that kills the bacteria. And I love where SDF is going. I go to a conference almost every weekend of the year, I feel like, and sit in lots of lectures, and across the gamut, people are using SDF in different ways. When a patient enters the restorative cycle and we, remove the tissue, we're not really killing the disease. The bacteria is still present. So what I love about SDF is it's a medication that actually kills that cariogenic bacteria. There are some, downsides to it. It does stain active lesions. So you get, you can have aesthetics. But I work in the, public health realm mostly. And, I work with people who the nearest dentist is 3 hours away. Like they would rather have a black spot on
Absolutely.
their tooth than, have a abscess and pain.
Absolutely.
Yeah.
I feel like also, this is my experience with SDF, is we use it on a very specific population as well. A lot of people who were in a situation where they would present and it was just broken teeth everywhere. Like the aesthetics weren't really all that important to them anyhow. And then we tried to do as much as we could. Like you talked about glass ionomer earlier. We tried to do like a glass ionomer over the top of it. So it's just a little bit aesthetically pleasing, but it's not like, oh my gosh, the most amazing. And we tried to do a lot of like self-cure. We'd have to use a light and because that does make it worse. But it used to. I don't know if it still does. It's been a while since I placed it. But I know you have more to say. I know you have a lot more to say, but I'm going to have to stop this right now. But I would love for you to come back and we talk about maybe some other things as well in the future.
I'd love that.
I think that you're absolutely amazing. I can't believe we haven't met until just now. And but I would like if the listeners had any very specific questions for you, if you're open to like an email address or something they could contact you by.
Of course. Yeah. So I can be found on LinkedIn, Jessica Woods. I'm on Instagram. It's at Executive RDH. And my email address is Jessica Woods. So WOODS, Jessica spelled JESSICA, RDHAP@gmail.com. Feel free to shoot me an email. I always love connecting and sharing more.
And everyone, we will have those in the show notes. So if you can't remember that on your head, just click on the little title of the episode and notes show up and there it is. So thank you again for being on. This was awesome.
Thanks, Andrew.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.